Hello, my name's Amer Shoaib. In this podcast I'm going to talk to you about metatarsalgia. The subjects that I'd like to cover are the definition, what the differential diagnosis is, what you need to look for in the history and examination including special tests, what different options there are for the various diagnoses, and then we'll look a little bit at outcomes before summarising. Metatarsalgia is not a diagnosis, it's in fact just a symptom. But what it means is that there's pain in the forefoot in the region of the metatarsal heads. There are lots of different causes that can result in pain in around the metatarsal heads, and although it's not actually a diagnosis, it's something that you may just use for convenience in correspondence, especially when you're not particularly sure of what the diagnosis may be. The differential diagnosis is quite wide. The reason may just be that the patient is obese and they're excessively loading their foot, or they may have diabetes and they have mononeuritis multiplex resulting in pain in the foot. The pain may be resulting from a hindfoot problem. If the patient has an equinus deformity, then when they're walking, the only part of their foot that ever touches the ground is the metatarsal heads, and this will overload and cause pain. Tarsal tunnel syndrome, which is pain in the hindfoot on the tibial nerve as it splits into the medial and lateral plantar nerves, can also cause pain in the forefoot. In the midfoot, if there's a geometrical problem such as the metatarsals pointing too much in the plantar direction, then this can cause overloading of the metatarsal heads and consequent pain. In the forefoot, if there's synovitis from rheumatoid disease, this can cause pain in the metatarsophalangeal joints. If there's a prominent condyle of the metatarsal head, this can lead to pain from point loading. Transfer metatarsalgia means that the great toe isn't bearing the load that it should do, and consequently the lesser rays are taking too much load, and this causes pain. A large part of this problem is from hallux valgus, and sometimes the treatment for hallux valgus, especially when a Keller's procedure has been performed. A Morton's neuroma doesn't actually refer to a neuroma, but pain which appears to be coming from one of the interdigital nerves. Mechanical pain can also be caused by high heels, so that the foot is pointing in a very plantar direction and all the load is being put on metatarsal heads. In the forefoot, if the toes are clawed or hammered because of a short toe box or long toes, then the proximal phalanx will be pushing down on the metatarsal head, and this can push it into the sole of the foot, and this is known as the plantar plunger effect. Again, there's overloading with consequent callosities of the skin and pain. There may be stress fractures in the metatarsals, which is causing the forefoot pain. A lot of people refer to problems with the metatarsophalangeal joints as being caused by instability of the joint, but whether this is cause or effect is debatable. And Freiberg's disease, which is avascular necrosis, can also cause pain in the metatarsal head region. When we're taking a history, we need to ask about the age and occupation, and then we need to ask very specifically about pain. Now, when I was at medical school, they taught me this little rhyme. I keep 6 honest serving men, they taught me all I knew. Their names were what and why and when, and how and where and who. And the reason this is quite useful is because you need to ask about all facets of pain. And this is helpful because it can then give you particular patterns of pain which will help you to make the diagnosis. So Morton's neuroma, often patients describe pain between metatarsal heads. It's worse when they're wearing leather shoes or closed footwear, and better when they're wearing trainers or if they're in bare feet. The pain can radiate into their toes and cause paresthesia, or it can radiate up towards the ankle. Transfer metatarsalgia means that you're not loading your great toe and you've moved your load to the lesser metatarsal heads instead. Sometimes patients can even walk on the lateral border of their foot, and the usual reason is that they've either got hallux rigidus, which they try to avoid the pain of their great toe by moving their foot are walking in such a way that they're putting their weight on the lateral side of their foot, or a hallux valgus, which again leads to loading of the lesser rays. Patients often describe having a stone in their shoe because it feels like they're walking on the metatarsal heads, and they often have hard skin underneath the metatarsal heads. If the patient's got an equinus deformity or a plantaris deformity in the midfoot, then they feel like they're walking on marbles because they're actually walking on the end of the metatarsal heads. You also need to inquire about diabetes or neurological problems. Ask the patient about their shoe wear, and ask if they have specific pain, as an isolated prominent condyle can cause very specific point loading with hard callosity over the top of it. As well as pain, you need to be asking about the medical and surgical history, neurological history, callosities and shoe wear. When you're examining them, you want to make sure that when they're walking, they don't have the forefoot as the initial point of contact in gait. You want to inspect their shoes to look for wear which is abnormal or orthotics. A silver scales test is to test for gastroc tightness. You do this by examining how much dorsiflexion the patient can achieve with the knee extended, and then flex the knee completely and see if the dorsiflexion is increased. If they can dorsiflex more, then the gastroc must be tight. You also need to look for a negative silver scales test, because if they're in an equinus with the knee bent and the knee straight, then that means they've got a tight TA in general. Look for callosities which indicate point loading, splaying, which might indicate Morton's neuroma, and also look at the lengths of the toes, which may be abnormally long. Feel for the prominence of metatarsal heads, feel for the callosities, and look for point tenderness, especially over sesamoids. It might be worth performing a Mulder's test if you suspect a Morton's neuroma. You perform this test by putting dorsoplantar pressure on the interspace using a thumb and finger, and then compressing from medially to lateral the whole foot, which can cause exacerbation of pain. As well as standing AP oblique and lateral, which might give you a definitive diagnosis. If you suspect that they're overloading one particular metatarsal head, it might be worth performing a condylar view, which is also known as a skyline view, and the way that that's performed is demonstrated on the right. If you have the facilities, it might be worth performing plantar pressures with pedobarography or Harris mats. Nerve conduction studies are indicated if you think that they've got tarsal tunnel syndrome. Ultrasound and MRI scans are often useful. Myerson wrote a paper which described poor sensitivity of MRI scan and ultrasound scan for Morton's neuroma, but the quality of scanners these days is so much better that the sensitivity is approaching 100%, and it may actually be that the evidence in the literature is wrong. Whenever a patient has a problem, you can always consider conservative management. You'll be able to see here that there is a bump on the insole, and that's called a metatarsal dome, and this pushes up on the metatarsal shaft and offloads the metatarsal head, so hopefully you're going to relieve the pressure that's being caused. If you find that it's not just one or two metatarsal heads that are a problem, but in fact all of them, then you might be able to use a metatarsal bar, which has a pad which goes all the way across. And you may also want to consider using silicone insoles or extra depth insoles, which are going to spread the load of the foot so that they're not point loading in any one place. If you think that the patient's got gastroc tightness, then you might consider using a night splint, although patients don't really tolerate these very well, or you might try physiotherapy in the form of eccentric loading to stretch the gastroc. The surgical options include a gastroc slide, and this can be illustrated on the right. You can see the gastroc muscle bellies. Inferior to that, you have an aponeurosis, and this aponeurosis eventually joins the soleus tendon to form the Achilles tendon proper. If you divide the gastroc fascia, then what you'll do is allow the gastroc aponeurosis to stretch and this will release the gastroc tightness. The De Vries osteotomy is actually for prominent condyle, and the way this is performed is by performing a dorsal incision and plantar flexing the toe, releasing the collaterals, and then using a saw or the Lambert's osteotome to take off the plantar aspect of the condyle. Vars osteotomy involves a dorsal approach, again releasing the collaterals, and then performing an osteotomy of the metatarsal. Now it's important that this is done properly. You'll see in the top picture there that the osteotomy line is pointing in a plantar direction, and if you're sawing downwards, unfortunately when you displace the distal fragment proximally to shorten the metatarsal, you will in fact cause the metatarsal head to depress rather than elevate, and this will worsen the problem. And you can see this in this small video. So the head's going down instead of going up, and this will make their point loading worse. So instead of that, what we can do is perform a different type of osteotomy with the osteotomy pointing uphill rather than downhill, and when this is translated proximally, this pushes the distal fragment uphill, so the head is actually being elevated rather than being depressed. And this can be held with a holstered, and then use a wire to make a guide hole for a spin screw. I often use a second cut, and we're going to have a look at some clinical pictures now. So to find the metatarsal shaft, we make an incision in between the extensor tendons. We release the collaterals by turning the blade at 45 degrees and cutting into the side of the metatarsal head. And here you can see it being done on the lateral side. We make a saw cut, and the saw cut necessarily has to start within the articular surface in order to get that upward slant. If we look from the side, you can see that although this looks pretty good from on top, in fact we're just about parallel with the sole of the foot. So we're just making a fairly neutral cut. Here we've made the first cut already, and I'm now about to make a second cut. And I've made my second cut, and I've now removed the garlic slice, which is about 2–2.5 centimeters long, indicating that I've made a long osteotomy, and hopefully this is going uphill. I'm now going to fix it by putting in a spin screw, and there's the result on the x-ray, and you can see the second and third metatarsals have been shortened and held adequately with the spin screws. Another type of osteotomy is the ochre osteotomy, which is a French name, osteotomie cervicale de ressuscement axial, and jokingly we call this the Bindi osteotomy. It's an extracapsular osteotomy, and it's obligatory to perform a second cut to remove that garlic slice. When you want to perform your fixation, align the plantar surface and not the dorsal surface, and you can use a spin screw again. The BRT osteotomy is an oblique osteotomy in the proximal part of the metatarsal. It's a closing wedge osteotomy, and you're going to leave a hinge on the plantar surface, which you can fix the osteotomy with a headless screw. The results basically for any type of treatment are very good, although it's interesting that neurectomy for Morton's neuroma only carries an 82% good and excellent result rate, indicating that nearly 20% of patients have only a fair or poor result. So in summary, metatarsalgia is a symptom, not a diagnosis. There are lots of different pathologies that can cause it. You need to try to establish what the diagnosis is from the history and examination, and then you can direct your treatment, which can be either conservative or surgical. And if you have the right treatment, which is particular to the pathology that you've isolated, then you're going to get good results.